trick you into thinking other things. The newer monitors are pretty good, and they actually will tell you when there's artifact. So if you ask the new monitors to give you an EKG diagnosis, they would actually say diagnosis not possible because of artifact, because of 60 cycle interference, you know, different reasons why it could cause it. So it's pretty hard to trick the new ones. Okay, but again, there's a lot of different reasons why, and sometimes, you know, it's just the patient's not lucky, you know. And again, whether they live or die depends on how early CPR is being performed. And again, with the assumption that it's adequate CPR, they really say that probably only about 10 to 20% of CPR is adequate. They were not pushing deep enough and fast enough. And if you looked at CPR beyond probably the 2 to 4 minute mark, the number is even more dismal because people are tired, okay? And even with mechanical CPR, if the machine is not placed properly, okay, if you read some of these studies where they ask people to quickly in a pressure situation, they try to mimic a cardiac arrest situation. So they tell people quickly, you know, put the CPR on a lifelike mannequin, not like a CPR mannequin, but a lifelike mannequin. Quickly put it on, you know, in less than optimal circumstances. People yelling at them, not good lighting and stuff. A lot of times they don't put the machine on properly, right? Where should that disc, that suction cup actually go? Not high up, but on the lower half of the sternum. And a lot of times people are reverting to the nipple line, which actually is a little too high up. The reason they teach the lay public to look for the nipple line is what? They don't want them to have to think, right? It's better for them to do something than do it perfectly. So when they teach lay people CPR, you know, nipple line is something very easy to pinpoint, okay? Again, I guess in some situations it may be, you know, a little mobile, but you know, for the most part, it's pretty, you know, whatever. You know what I'm saying? So, but for us, really, we should have our hands on the lower half of the sternum because what does that overlie? The ventricles, right? And that's what we want to push on. There's no sense of pushing on the atriums. We need to push on the ventricles. So, okay, so let's look at Vfib. Would we call this a coarse Vfib or a fine Vfib?
I call it a fine.
That's a fine Vfib, right? That's a low amplitude Vfib, okay? That's probably somebody who's been in for a while. And when I say a while, I'm talking, you know, 5 minutes. I'm not talking 5 hours, right? Nobody's going to be in it for, you know, an extended period of time. That would be a coarse Vfib. So you see how it's a little confusing? You may think it's like a Vtach or a Torsades. What's the difference going to be? Assessment-wise, this patient is not going to be responsive, is not going to have a pulse, is not going to be talking to you. Even if it turns out to be Vtach without a pulse, we treat Vtach without a pulse as what? Vfib. So it doesn't matter. So, you know, even if this turned out to be for some reason, or Torsades, or something exotic, okay, if the patient has no pulse, you're still going to defibrillate them, so it doesn't matter. And your AED would still defibrillate them, so, you know, it doesn't matter. That's actually why it's better to have an AED without a screen. Because you don't want to doubt yourself and say the machine is, you know, is wrong, okay? Most of the times I'd always say trust your assessment, okay? But unless you're really doing EKGs on a regular basis, I would say not to have an AED with a screen, besides the fact they're like 5 times more money, okay? And then the last thing is if we have Vfib untreated, so we started with this, started to go to this, eventually it's going to go to something called asystole or cardiac standstill, which is that the heart is no longer having any electrical or mechanical activity, okay? And, you know, obviously the patient is dead. The chances, the prognosis of bringing that patient back are fairly minimal, okay? They're always going to say to check that the cables aren't unplugged or something like that, because years ago that was a problem. But now when your cable's unplugged, what does the machine do? Starts screaming and yelling, beeping, gives you a signal on the screen. It actually tells you what cable is unplugged. So I don't want to say it's idiot-proof because I'm sure there's somebody who will, you know, prove that wrong. But you know, they're pretty good at not letting us, you know, do much in the way of damage until we shut off all the alarms. You know, nothing makes me crazier to walk into a monitored setting, and you look at the machine and it's totally quiet. And there'll be a little light that flashes every 10 seconds to say alarms off or alarms silenced, which means that somebody decided to shut every single alarm off. So if anything happens to that patient, nobody will get any idea. The better way to do it would be change the parameters of why the alarm is going off. In other words, if the alarm is going off and you don't need it to go off, maybe because the patient occasionally has a heart rate that goes to 50, and probably the default setting is a heart rate below 60 will cause it to alarm. But you know that the heart rate going to 50 is not a bad thing in that patient. So what do? You set the parameters. Tell the machine to alarm at 45 instead of, or 49 instead of 50. Now you still have the backup of the alarm, okay, to keep an eye on the patient in case you're too busy. and it's not going to go off all the time and make you crazy. But you'll see all the time, if you walk in and look at these machines carefully, it says alarm silenced. And there are some hospitals that actually in policy say you cannot silence a machine because of the problem where they've walked in 2 hours later and looked at the quiet machine and also looked at the quiet patient, and why was the patient quiet? Because they were dead, right? So it happens, it happens all the time. Okay, there's a thing that we used to have to do with fine Vfib, okay? So picture this scenario where you have this, but it's even a little flatter. So it's at that moment, that 1 minute before fine Vfib goes into asystole. Your treatment would be different depending on what it is. If it's fine Vfib, what's your treatment? Defibrillate. If it's asystole, defibrillation is useless, because when you defibrillate the heart, what do you actually do to the heart? Stop it. So in other words, if they're in asystole and you keep on defibrillating it, you just guarantee that the patient is going to remain dead. So what they're talking about in this slide, okay, is that there could be a possibility, this is all theoretical, that the patient is in a very, very low amplitude Vfib. They call it fine Vfib, okay? And really there, the treatment may still be to defibrillate, okay? Versus being in asystole where the treatment would be to give them epinephrine. Now I'll just tell you it's all stupidity, because if the patient was in fine Vfib, right, and you defibrillated them, what would be the outcome of the defibrillation? Asystole. They're not going to come back in a perfusing rhythm, because if they're at that stage of fine Vfib going into asystole, how long have they been in cardiac arrest? At least 5 to 10 minutes, right? Nobody's going to jump up and say, thanks Frank, that's what I needed and now I can go on with life. It's just not going to happen. So it's a stupid thing, but it's something that's on every test. It's something, that you always have to, and what they used to say was that you had to switch and look at it in multiple leads. So in other words, if you looked at this fine Vfib in lead 2, you had to switch to lead 1 and lead 3 and make sure it was still, still look like asystole. If not, you should shock the patient. So again, and not anything real important there. Okay, why does somebody go into asystole? Most of the times because it's the end of their life, right? It could be a rhythm that you will see post-defibrillation, because that is what the defibrillator is supposed to do. When you shock somebody who's been down for a long period of time, you're stopping their heart, and there's no guarantee that it's going to start up again. I mean, if we shock somebody who just collapsed, okay? I mean, if I, God forbid, went to Vfib right now, I know that 90% of you would run out of the room because you could leave, but the 10% that chose to save me, right, if we could find a defibrillator, do you think we could find a defibrillator in this hospital quickly? I'd be deader than dead. There is no AED in this hospital anywhere to be found. Because why? It's a hospital. They don't have to have one because they have defibrillators. So there will be no AED, any place to be found. But, if you shocked me quickly, let's say if somebody actually has one in their car, and you shocked me quickly, by the way, I do have one in my truck if it happens, okay? And the combination is A3294 to get into my car, okay? So if you shocked me quickly, okay, what could actually happen? My heart is not stunned. It's not hypoxic. And I could actually, you could stop it, and then it could immediately, the pacemaker could fire up again, and I could actually generate a pulse, generate perfusion, and wake up, because my brain was not deprived of oxygen. But this guy that's been down this long, it's not going to happen. It's all just theoretical. Okay, so what is the rate of ventricular asystole? Nothing, right? So, flatline, okay? Sometimes you'll see flatline with an occasional complex, right? So that's the dying heart, the agonal rhythm that we talked about before, just where they get an occasional beat. We use the term agonal breathing, which is what? Slow, almost non-existent breathing. An agonal pulse is just a slow, almost non-existent pulse. Very rarely do agonal pulses actually generate a pulse. So we should really probably call it an agonal rhythm, not an agonal pulse, because there's no actual pulsation with it, okay? And then the last cardiac arrest is something called PEA, pulseless electrical activity. It used to be something called electromechanical dissociation, but I think they thought that was more confusing and that this would be an easier way to explain it. So pulseless means what? Dead. Electrical activity means they're dead, but if you looked on the monitor, they have a rhythm that should be able to generate a pulse. So now you have a situation where the electrical conduction system is working fine, but the mechanical pumping action of the heart is not working, or maybe even the mechanical pumping action of the heart is working, but there's no blood to push. So why would somebody go into PEA? So let's go through some of the reasons, okay? It could be they have a massive heart attack, they've damaged their left ventricle, okay? The electrical part of the heart is working perfectly, the left ventricle cannot pump, therefore they are dead, right? What else could it be? They were stabbed in the heart, okay? And all the blood now is in their pericardial sac or their chest. The heart, for some reason, electrically, is still working. It wasn't damaged yet. Is this, I mean, let's put it this way. Is this electrical activity going to go on for 30 minutes? No, because the heart is deprived of oxygen. But they're talking that you're catching this patient when they're fresh. But all their blood spilled out of their veins and their arteries. The pump is working fine. The electrical part is working fine, but there is nothing to pump. So therefore, there is no pulse. Right? So there's a million different reasons why it could go in. So what do you think the treatment of PEA is for? So short term, it's CPR and epinephrine, but is that really going to save the patient? Absolutely not. The treatment is to find the underlying reason. And they actually have something called the H's and the T's, which are the terms or the conditions that could cause this. Hypoxia, hypovolemia, hydrogen acidosis, coronary thrombosis, cardiac tamponade. You know, so there's lists and lists. And what really the treatment would be, you'd have to pick and look at that patient and say, based on the scenario, based on the mechanism, based on the history, I think it's this. And then you try to rule that out and treat that. If that doesn't work, you say, okay, that was wrong, let me try the next one. So what is obviously the prognosis of PEA? Pretty poor. But there's a new thing they're doing, which is that in university-level hospitals that actually do cardiac bypass surgery, and they have a heart-lung bypass machine, okay? And there's a cheaper version of a heart-lung bypass machine called an ECMO machine, okay, that you may actually see in a community hospital setting if they're real progressive and aggressive. But basically, what do? They very quickly cannulate an artery and a vein in a patient, hook them up to this machine, which then sucks the blood out, oxygenates it, and pumps it back in. So it becomes an artificial heart for the patient while you're trying to figure out why the patient is in this condition. So what does it prevent? Brain damage, right? Organ failure. And they keep people going for quite a while on these machines while they're trying to figure out what is it that's not working and why are they in this condition. So much bigger. I know Australia, it's a huge thing in, okay? It's a big thing in certain European countries. It's in certain states in the United States, it's a big thing, where they will very quickly, and they're actually, you know, talk of EMS systems, because really all you have to do is be able to cannulate 2 blood vessels. So if you can start an IV, you're just cannulating bigger blood vessels, typically in the legs. So if you can start an IV on a small vein, you can start an IV on a big vein. So it's feasible to do it in the field. Again, you're talking about a dead patient, so you really can't screw up if you don't save them because they were dead already, you know. So it's kind of a last-ditch, you know, last-ditch type of thing. But that's would be the treatment, and that's all the new literature is going towards when you have people in this PEA, is to get them on an ECMO machine, okay, and then try to figure out why they're in that condition, and then treat it while the machine is keeping them alive and perfused. Okay, so is there any one rhythm that could be PEA? Absolutely not. They could be in a sinus rhythm, they could be in a junctional rhythm, they could be in any rhythm, okay? Any rhythm that should have a pulse and does not have a pulse would be PEA. So I can't tell you what rhythm they would be in. This is a very common, okay, you know, cardiac arrest situation in trauma, where you get the patient, okay, they're a traumatic injury, you put them on the monitor, okay, you see a normal rhythm, but there's no pulses with it. What do you think the etiology is? They bled out. Right? They bled out, or maybe they have a tension pneumothorax that's pushing on their heart and not letting it fill. So again, treating the PEA would be CPR and possibly some epinephrine to improve the pumping action of the heart. But long term, the treatment is to find out why there's this interference with the blood flow, and then, you know, make that better. So there's a lot of different reasons. Again, a long time ago it was called, not a long time, but you know, a few years ago it was called EMD, electromechanical dissociation. In other words, the electric's working, the mechanical's not. There's a dissociation between the electrical part of the heart and the mechanical part. So, you know, hypovolemia, massive myocardial damage. Ventricular rupture would be, you know, a death sentence. You know, if you remember, we talked about if you blow out, you know, a lot of times people will survive a heart attack, okay, and then 6 months later just drop and die. And what happened is, where you had the heart attack, what develops in that area of the heart? Scar tissue. The scar tissue does not move anymore, so the rest of the heart is contracting, the scar tissue is staying in place. And sometimes, if it's what's called a transmural heart attack, where the damage is through the mass of the myocardium, you can get a heart attack where it's the surface that's damaged, the inside that's damaged, the middle that's damaged, but the worst one is a transmural, where it's like a whole piece through the depth of the ventricles is damaged. So now what happens? You decide to run for the bus. You increase your pumping action of the heart. You increase your blood pressure, right? So the heart is straining, and what happens to that little scar tissue? Pops. And what happens to you? Within, what, 10 seconds, 20 seconds, blood is filling up your pericardial sac, right? Because your heart is in that sac. The pericardial sac is now crushing down onto the heart, and you're dead. You know, so there's nothing to do for that patient. So a lot of different reasons why a patient can go in. Again, we'd have to figure out why and be able to treat it to be able to save that patient. Okay. So let's just do a quick review on the ventricular rhythms. We started with PVCs. Okay. Again, we said nowadays we're not that concerned about PVCs. Okay. Unless they're in a setting of a heart attack patient where we really feel there's potential, like they're having a lot of PVCs of different shapes very often, okay, and stuff like that. So like I told you, I have a guy at work, you know, if he has a caffeinated beverage, we'll have PACs, PVCs and stuff like that. So the biggest, you know, trick is when we have a meeting, he tends to talk a lot. So what do people do? So when he turns his back, they switch his decaffeinated coffee with caffeinated coffee. And about 10 minutes into the meeting, he says, I have to go take my medicine. And he leaves, you know, because his heart is beating too quick and stuff like that. So, you know, some people are very susceptible to caffeine. Okay. In the military, they actually give caffeine tablets, caffeine pills to service people before they go out on, you know, missions, because a little bit of caffeine raises your level of awareness, makes you a little more alert. So, okay, so again, most of the times we're not going to worry about PVCs. Oxygen, a lot of times we'll get rid of it on its own. It's only when it's a lot of PVCs in a setting that we're real concerned that we may have to give medications and stuff like that. Okay, idioventricular rhythms are not just premature ventricular contractions, but where the ventricle has now become the dominant pacemaker of the heart. We're going to know that again because the width of the QRS is wide and there are no P waves or anything like that. Okay, so those patients are typically unstable. It really depends on the rate of why they're unstable. If it's too slow, it's because the heart is not beating enough times a minute and we'd have to increase the heart rate. If it's the accelerated idioventricular, the Vtachs, then it's because it's too fast and we'd have to actually slow down the rhythm. So it really depends on which one, but either way it's just a wide ventricular rhythm. And again, it comes down to how the patient's tolerating it. If they're not tolerating, the treatment will be based on the rate. If it's too slow, we speed it up. If it's too fast, we slow it down. Okay, so again, we're talking about whether it's perfusing or non-perfusing rhythms, stable or unstable rhythms. Okay. Vtach is considered probably the most unstable of the rhythms because it's the fastest, and that's when you have a ventricular rhythm at a rate of over 100, and how you're going to intervene depends on the stability of the patient. Okay? If they're unstable, it's usually electricity. If they're stable and you can get an IV, it's usually medications. If they're stable and you cannot get an IV and you have a long time before you get to a hospital, you may have to use electricity, okay? Because it's not considered a rhythm that somebody will stay in for a long period of time. Okay, Vtach without a pulse is treated exactly the same as Vfib, which means that the treatment would be to do CPR and to defibrillate the patient as quickly as you can. Okay, and then we go into, you know, Vfib is not good, and we know that. As far as the energy levels, the AEDs you're using use biphasic technology for defibrillation, which actually most monitors do also now. The advantage of it is that the energy levels you have to apply to the heart are much lower. So this old days of 200, 300, 360 really should not be, patients should not be shocked at those levels. They are still, but they should not be shocked at those levels. But AEDs, because they come pre-programmed, will probably shock at much lower. Like the first shock will probably be 150. Second one may be 200, next one may be like 250. So what's the advantage of shocking at a lower energy level but still being possibly able to accomplish the same, which is stop the Vfib? The more electricity you put into the heart, what? You know, everybody understands every time we shock the heart, what are we actually doing to the heart? Damaging it a little bit, right? So if you could do it at a lower energy level, okay, it's much better. If you could do it chemically, right, that's the holy grail of medicine, is to be able to take somebody who's in Vfib and give them a shot of medication and get them out of Vfib. If any one of us could do that right now, you know, we'd be sitting having lunch with Bill Gates and Warren Buffett and discussing, you know, how we're going to leave our billions to